for giving me the opportunity. So I was called by Dr. Suleiman the night before, and he said, can you do something to fill in a blank? And so this is a very last-minute presentation that I prepared yesterday, sitting in the morning. So the only positive is there's no overlap, because nobody has talked about this topic before. So during the day, we already said that the incidence of cardiac anomalies is about 25% of all the anomalies. So this is the most common anomaly that we see in the babies. And this constitutes about 1% of all live babies. Now, there are various protocols through which we pick up cardiac anomalies. If you look at the four-chamber heart, we pick about 40 to 50% of the anomalies. If you extend these into the outflow tracts, we increase our detection to 70 to 80%. Now, we also know that the experience centers where the scanning is performed by their fetal medicine, trained consultants and specialists, this detection goes to 80 to 90%. But as Dr. Suleiman said, majority of the cardiac anomalies occur in the low-risk population where there are no risk factors. Now, despite we having a good detection rate of 80 to 90%, there's a significant variation in the detection rates nationally, internationally, from center to center, and this could be as low as 30%, 40%. This is a very nice paper, which looked into why we miss congenital heart defects. And this was a study that was undertaken in the northwest of Netherlands. They looked at the whole 1 year of between 2015 to 2016 into all the cardiac anomalies that were missed. And they picked up about, they did a total of 114 isolated severe heart diseases. 50% were missed and about 50% were detected. The most common missed anomalies was DGA, which was 17%. Aortic coarctation was 16%. You can see tetralogy about 10%. I think a lot of other studies have a higher missed rate for tetralogies. And so they also analyzed further as to why these anomalies were missed. And the findings were very interesting. There was no difference that was found in the fetal position, the obstetric history, maternal age or BMI, or gestational age at examination between missed and detected anomalies. So it is very difficult to say that the mother is high BMI, and that's why we missed the anomalies. And the only factor that they picked up, why we picked up the anomalies, was the experience of the sonographers who were doing the scan. And if they were scanning in a very high volume center where they were scanning loads of patients every day, their detection was much better. So we know that practice makes perfect, and that probably is proven by this study. So how can we achieve a high detection rate? We need to have the right equipment. We need to, the scans should be performed by the qualified, trained people. It should be at the right place. So if it's a screening, it could be performed in your secondary level, but if it's anomaly that you're suspected or in a high-risk population, should be in a tertiary fetal center. What is the right time? We have discussed that during the day. 18 to 22 weeks is the time when we do the fetal echoes. But there is an increasing push at looking at fetal hearts between 11 to 14 weeks. And this is my own experience, and I audited my practice. About 2 years detection rate was 67% for overall anomalies in the first trimester. And we do pick up a lot of first trimester cardiac anomalies if we look for it. So education training goes a long way in this. I've already touched the topic, who should perform the scans? Targeted scans, whenever we do any targeted examinations, our detection rates are much higher. This is true for any radiological investigations. If you send a patient for a CT scan, and if you not put your reason for looking for a certain thing, you will not get a better detection. So it also applies for fetal medicine. So these are the standard views that most of the guidelines have in their protocols. They include the 4-chamber view, the left and the right outflow tracts, 3-vessel, and the 3-vessel tracheal view. And there are various protocols, which is the ESOG, the American guidelines, or the fetal anomaly screening program from NHS England, and they will guide us as to what is mandatory and what is additional scanning. When we look at this, I think I feel very lucky that my scan machine, thankfully, does not look like this. And we all, we've seen English movies where, if any of the lights go on in the cockpit, they pull out the manual. Thankfully, we don't have to do that. We don't have time to pull out the manual. Nobody would trust us if we did that. So the big question I always ask myself, and I think all of us need to ask yourselves, is do we actually get the best out of our machines? Are we utilizing our machines to its full potential? So what does a good scan machine that will allow you cardiac scanning or fetal echo? So it should have a two-dimensional capacity. You should be able to do color and pulse Doppler, M-mode imaging. You should have probes that can have a higher frequency, ideally between 4 to 12 megahertz, so that you can have better, definition. The views should be recorded, and you should be able to take cine clips of your echoes. Color Doppler is a must, I think, for any echo. You should be able to see the flow across the cardiac walls. You should be able to see the systemic and the pulmonary venous flow in and out of the heart. I think a lot of us do not do the M mode so effectively, I think, and that's something that we should try and do it, and as a routine, try and practice M modes on normal hearts, and so when you really need it, you would know what to see. Now, this is me, and most of the times I take pictures like this. I have no training in photography. I have the best possible camera, and I'll just take 100 pictures and hope that some of them will come out nice. But that's not how fetal echo should work. We should not just wait for the baby to turn around and you see views, and if you see the 4-chamber heart or outflow tract, fantastic. We should be doing a targeted sequential systematic examination of the heart. Most of the people I know in the audience are fetal medicine consultants who have been practicing many years, but this is a slide for the people who are new to the scan machines, that you have to learn how to hold your probe properly and how to orientate yourself properly. Holding the probe and learning it at the right way from the start is crucial, because that will save you from a lot of repetitive strain and as well getting confused while you're scanning. This is again very basic. These are the different movements of the ultrasound probes that you should be aware of, so that you can get the best image that you're looking for and not waiting for a chance. As we've said earlier on in one of the presentations, the heart is a very, very small organ, and you only need a very little subtle movement of your wrist to get all the sweeps that you want. Rather than going from making big moves, you will not be able to see much in that. And there are lots of standard controls that we all have, and we should be able to utilize all of these and should have some understanding of how those things work, so you can optimize your settings. And one thing very important is we should be scanning with both the hands. So the one hand holds the probe, whereas the other hand should be continuously controlling the panel. So you're adjusting the depth, gain, you're doing all the adjustments on the machine. So the frequency is important. You should have a higher frequency. The golden rule is turn up your frequency to the highest so that you can get the best quality images. We know that there's a trade-off between penetration and resolution. So if you have a patient with a high BMI, you might want to use a lower frequency, in which there will be a trade-off between the resolution. Overall gain is just like the volume button on your radio. If you don't see anything, our reflex is we crank up the volume or put the gain up, and this is what happens. You can everything becomes very white, or if the gain is low, everything becomes quite dark, and we want something like in between. And there are other ways how you can adjust the gain on different segments of your image. So the TGC is the button that we see a panel and looks different in all possible machines, but you want to have a uniform echo brightness in the display, which is a better way of controlling your gain. Focal zone, we all understand what the focus does, so you have to focus at the point where you want to see. So the best image resolution occurs in the section which is passing through the focal zone. The images, that picture explains it very well. So if your focus is there, you will see the two dots separately. It comes up across as two separate shadows. Whereas if you're out of focus, it will appear as one single image there. Again, depth is very important, that if you have to see a structure, I don't know if my cursor does not work there. So here, if you have something down there, you would miss it if you have not used the whole depth. So that your possibility, if it's too shallow, you'll just see things above and waste all the space there. Also, if you've taken a big depth, what will happen is your machine is working hard to go deeper down and take the images of structures that are not relevant to you. So your sweep goes slower and you're wasting a lot of time. Sector width, again, this image shows that you have taken a lot of wide segment and you've wasted your scan machine's capacity to pick up the relevant bits. You're only interested in the middle part, which is the brain, so you don't need your machine to work hard and pick up unnecessary stuff in there. So you need to reduce your sector width. So what is dynamic range? So it tells us how many Derwent color pencils are in your box. This is so the next picture will tell you here. So if you use your dynamic range, you can put a lot of shades of gray into your image, so you get more definition of different organs. Whereas if your dynamic range is not set accurately, you'll just get very black and white images. So reducing the dynamic range, it cleans up your image, and you get, so especially good for looking at hearts. The pitfall is it can remove real echoes from the display, especially for kidneys and liver, where you want to see minor echoes or calcifications or blood vessels. That will disappear. Tissue harmonics is the same as the frequency button on your radio. So if you are used to that old radio where you're fine-tuning to get into a station, you cut off all the noise and you just focus on the main radio station. It's exactly the same. It improves the quality by eliminating weak echoes that cloud your image. And we have all had this problem. Obesity is a growing epidemic. All these women are also sadly at increased risk of fetal anomalies. And so it gets even more vital to get good images on these patients. So how do we deal with that? We want to, So the size of the panniculus is the challenge. It increases the distance from the transducer to the fetal organs that you're interested in. It scatters the ultrasound beams and thus degrades the resolution. A lot of sound waves the energy is absorbed by the adipose tissue, so very little reaches to the point of interest. And we know that about 50% of the anomalies are incomplete in the first go, and you have to call the patient again. Again, there are guidelines in different countries. Where I worked in England, you can call the patient one more time, and then if you can't see it, that's it. You document that you've tried a second time and you couldn't do it. I don't know how things work in other centers here in Dubai. 10 times you do it, okay. I'm not that brave, I would say. I'd try 2 times and give up. So we want an image from here to here, and how do we improve that? So as I said earlier, we have to drop the frequency, try a lower frequency, because we know that absorption is directly proportional to the frequency. So if you have a lower frequency, you have a lower absorption of that energy. There's less attenuation, more penetration, but you lose resolution. So we try and increase the depth. We try and bring the depth down to the area of interest. We lower the focus to the point of interest. We decrease the dynamic range, as I showed you earlier, and we try and turn off the harmonics. A lot of times you have to keep trying different things and see which one works. You have to keep optimizing and using your left hand. Avoiding the panniculus. We all have sweated on situations like this. So we try and go suprapubic and try and see. Sometimes you find a window there. If that doesn't work, tilting works a lot of times. The panniculus hangs onto the side, and you can go from one of the sides. So try and turning the patient left or right. Something recently I've started doing is going above the panniculus from the top. And in situations like this, I think a good thing is trying and filling up the bladder so it pushes the baby up, so you can go and try and get some information from the top. And this is the difference you see. If you avoid the panniculus, you can see the image here. That layer is very thick and with poor quality, and you can see much better definition here. And one thing I always do is when I start the scan on a high BMI, and this is a medical legal way of protecting yourself, take a picture with the full fat thickness and measure the depth, and that way you've recorded that you've really struggled on this patient. And the same thing, you've avoided the panniculus, and you can see the heart pattern here. Full bladder, as explained, it pushes the baby up, and you can probably go above the panniculus. The other thing I would also suggest is using the other hand to push the baby into a more favorable position. So don't be afraid. Try and gently nudge the baby to move on one side or the other, move the head round, and see if that helps. TV probes, I don't know how much it works with high BMIs. It depends where the fetus, I usually do it in the first trimester when the fetal parts are smaller, because you can imagine the penetration of the TV probe is only limited. So even when you're doing a 20-week fetus with a TV probe, you may not get the entire head or whichever part you want to look. But something you can try. When you're desperate, you try anything. Ergonomic tips, it's very important that we protect our backs, our shoulders, and our wrists, because we need it the next day. Good posture is important. Avoid prolonged twisting and awkward positions. We all do it because we are so desperate at the time. We want to finish the scan and get home, and we do that. But it's important we get into good habits. Raise the bed, put the head down of the patient. You do a standing scan just to avoid all these repetitive injuries. And last but not the least, avoiding bias against patients with obesity. I mean, it's very hard. It shows on the face when you're struggling, but try and be compassionate. There's no point telling the patient you're fat, that's why I can't see it, because most of them know that they are fat, and they're really feeling it inside them, and you don't want to make them feel even worse, you know. So it is important that we are compassionate and kind to them. Do not use any derogatory or negative remarks on them. Thank you.